It's truly an honor to be here to help host this incredible panel of speakers dedicated to advancing women's health. So let's introduce our next speaker, Dr. Catherine Marshall. Dr. Marshall is an obstetrician gynecologist based in La Jolla, California. Is associated with Scripps La Jolla Hospital, graduating from La Jolla University, Chicago School of Medicine. Dr. Marshall brings over 2 decades of experience to her practice. So tune in to hear her obstetrician gynecologist talk.
Hi, welcome. I wanted to tell you a little bit about myself. I'm a 53-year-old OBGyn, and I grew up around here. I married a radiologist and have 4 kids. Also a breast cancer survivor. So the things that strike me as interesting or important may be different than what you expected. All of us are connected to the OBGyn office in one way or another. And a recent movie touched on the differences in the male and female psyche. I loved the final scene of the Barbie movie where she becomes human, just like the Little Mermaid or Pinocchio. Her first exciting stop, dressed in business casual attire, is not to go to a job interview. It's to check in with a gynecologist. This is obviously a joke about her new anatomy, but it also inspires us to look after and celebrate our own health. So what does preventative care and lifelong pursuit of learning get you? As a wise person once said, chance favors the prepared mind. Does anyone know who said that? Louis Pasteur. So diving into women's health, I noticed that modern life is hard on women's reproductive organs. We are delaying childbearing. If you compare the work our ovaries and uterus do, menses as the proxy measure, you see that 200 years ago, women did not have access to contraception. They would only experience about 100 menses in their lives. Now we expect twice as many cycles, or incessant cycles. Now we have fewer babies and much later in life. In 1970, when I was born, the average age of a mother with her first child was 21 years. In 2022, it rose to over 27 years. And so what is the price we pay to delay? And I ask all the working women here and their husbands and partners. Well, today I'd like to talk about some of the consequences of a frustrated reproductive system. There is a popular theory that letting women cycle, we are promoting inflammation and tumors. And indeed, there's a correlation to cancer when women have an early first period, late last period, and late childbearing, as the breast cancer doctor talked about, and it's out there. But wait, can't we just freeze our eggs? The cost is very steep, both for your metabolism and financially. And most women who freeze their eggs for later never use them, less than 1%. And if you happen to start your family in your 30s and beyond, you can expect slightly higher breast cancer rates and obstetric complications. In fact, if you start your family in your 30s, breast cancer rates are higher than if you never had kids. So to understand these risks and how they arise, I thought I would dive into some ovarian biology for a moment. In utero, we start out with about 3 million microscopic eggs. By birth, we have half as much. By puberty, we're down to 1/6 as much. By age 27, women's fertility and egg count starts to really plummet. By 41 years old, 50% of women are sterile. Menopause marks the end of the ovulation and ovulatory eggs. Do men have a biologic clock? Well, sort of. While they seem to have an endless supply of their germ cells, the amount and quality does go down, particularly after 45 years old. Which is to say, if you're older, you shouldn't, you absolutely should have kids. It just means that there's higher rates of miscarriage and other issues. So let's get back to female biology. You guys are all familiar with all of this. I want to point out uterus and the two two tissue types. We have the muscle, which is actually quite similar to cardiac muscle, that it's contractile and gap junctions, and you have a C-section or a myomectomy and you destroy that muscle tissue, it never grows back, it never heals, it's just a fibrous scar. Muscle of the uterus, we get fibroids, which are very common and expensive to take care of, and a rare cancer called sarcoma, not going to talk about today. The endometrium, or the lining of the uterus, this, you can see it on the slide there. Anyway, it's what's shed every month when we menstruate. It is the cause of a very common cancer in women, endometrial carcinoma. Fallopian tubes bear discussing as well, because since I graduated from medical school 30 years ago, there's a lot that's changed in what we know about female biology. It turns out the fallopian tubes connect uterus and vagina with the pelvic peritoneum and ovaries. We used to say, oh, it's all sterile. It's not. So more on that later. And finally, ovaries, which I'm going to go into quite a bit. A cervix, which is a preventative medicine success story. We have pap smears in the developed world. We have the Gardasil vaccine. These have decreased cervical cancer down to very small numbers of deaths, which is really a success story. All right, moving on. I wanted to do a slide sort of showing the monthly contest that happens every month in a woman's ovaries, whether she's on the pill or not, or the IUD or anything like that. There's something like the Hunger Games that goes on, where a cohort of eggs will come up and be in a race. There's only one, if you're ovulating and not on the pill, or if you're on the IUD, that will win the contest. Only one, at least if you're not having twins. At the end of the contest, the non-winners die and are absorbed, do not re-enter ovarian reserve. They're gone forever. So how many eggs we have left is called ovarian reserve, and we can measure it. This has changed since I was in medical school. You can do this with an ultrasound or a blood test, and it's called an AMH test. It doesn't directly measure how many eggs people have. Instead, it measures how many helper granulosa cells are active. AMH is made by the granulosa cells, which are like the egg's pit crew. They're a sphere around the egg. And for the men to get the gist, imagine each egg is the racer Max Verstappen. And those granulosa cells are like a Red Bull pit crew surrounding it and keeping it viable. So when does the gynecologist check AMH or anti-Mullerian hormone? It's usually if a woman is having hormonal problems or infertility, which is a lot of women. So looking at this slide, green is good, red is not so good. And so, in fact, if your AMH is less than 2, IVF doctors and the egg freezing doctors are not going to let you freeze your eggs, you're not going to get enough eggs, and they're going to insist you use donor eggs if you want to get pregnant. So this is an important measure of fertility for women that I think all women should know about. But what about that high number, over 4? What does that mean? All the time I see 4, 5, 6, 7, 8, and this is in the post-adolescent group. This is a sign of ovulation dysfunction, and we think at least 1 out of 10 women have this, maybe 1 in 5. And when they have this elevated AMH, they also will have other symptoms that brought them in for hormonal checkup. And really, it tends to be a young woman that has acne, male pattern balding, not where it recedes from your hairline here, not female pattern where the part gets wider. They get acne, they get mood changes, depression, weight gain. They usually, when you question them, have less than 9 periods a year. And that doesn't usually bother women. You don't usually say, hey, I'm only getting 9 periods a year. I'm usually pretty okay with that. It turns out that's not okay. You're not on hormonal contraception. Because it's a sign that something's going on. And when we do an ultrasound on these women, we often find their ovaries are in sort of a stunned state, where they have enlarged ovaries with abnormal looking follicles. They're not having the race cars are not making it to Le Mans. They're stuck in the garage, which can be good for fertility later on. And a lot of times these women will not be very fertile in their 20s at all. Will have fertility in their 30s and 40s. But aha, that's not the best time to have fertility for the other health issues we discussed. So, and to diagnose it, you only need 2 out of 3. So you could be a skinny woman with very few periods and acne and not have enlarged ovaries, and you count as PCO. And it's a syndrome, not a disease. It's more a cluster. We're still trying to figure out what's causing this. And by the way, perimenopause, another time of ovulatory dysfunction, is super similar to this time. It's also a time when women grow tumors. So what causes PCO? There are lots of theories, lots of things correlated. Certainly, diet has something to do with it. But what came first, the chicken or the egg? Is it the weight gain, high insulin that triggers it, or is it hormone dysregulation, the male hormones where they're not supposed to be, slow our metabolism? It's probably a little bit of both. There's also been studies that show these epigenetic forces in utero that play a role, microRNAs. Also, we have found that children who grow up with polycystic ovary syndrome have a history of having moms with higher AMH levels, and so being exposed to higher AMH in utero. 80% of the time this runs in families, but there's no specific gene. Only 10% found that gene. So that's why they're thinking, yes, some different proteins are being turned on here for these babies. So of the PCO syndrome, polycystic ovary syndrome, 50 to 80% of these women will become overweight or obese, particularly with this century's sedentary lifestyle. So it becomes an unfortunate cascade of insulin resistance. We get high triglycerides, which is linked to cancer, hypertension, which is linked to heart disease. We also get this estrone in adipose. So there are 4 major estrogens that we deal with: E1, E2, E3, E4. Estrone, estradiol, made in the ovary, estriol, which is made in the mom's placenta, and estetrol, which is made in the liver. And all of these are available in formulations, although no one wants estrone in a formulation because it turns out it's not very good for us. It's one of those things that feeds back to the ovulatory dysfunction, and it feeds tumors. So let's talk about female breast cancers. Obviously, breast is number 1, lung is number 2. And in 2022, we had more new endometrial cancers than colorectal cancers. What's the deal with endometrial cancer? And then what cancers are the deadliest in women? Lung is number 1. Number 2 is breast. Fortunately, uterine cancer is not as deadly, especially if it is caught early with preventative health measures, more survivable, getting better. Ovarian, however, is brutal. It's not even in the leading diagnoses, but it's extremely deadly. So let's review the big risk factor, endometrial cancer. It's estrogen, unopposed estrogen. Even being on opposed estrogen, hormone replacement, estrogen, and progesterone, those women are going to have higher endometrial cancers than women who are not on estrogen. And the risks that are up there, you can multiply them by each other. So if you are obese and diabetic, your endometrial cancer rate is 5 to 15 times the normal population. That's a picture of endometrial. Now, who wants to guess what cancer this is? It's not fallopian tube cancer. This is something very new that's been discovered in the last 10 years. The majority of epithelial ovarian cancers, which is the major subtype of ovarian cancer, deadly cancer, it starts in the fallopian tube. And this is why in the last 10 years, we OBGYNs have been recommending the removal of fallopian tubes whenever possible. You're having a hysterectomy, getting your tubes tied, your appendix is coming out. Just kidding, we don't. We just don't have any other great ways to prevent ovarian cancer. What do we? In the general population, let's say the relative risk of ovarian cancer is 1. The biggest risk is going to be these heritable genes, the BRCA1 and 2. It's going to raise the risk 13 to 46 times. So that's really important. If that runs in your family, first degree, second degree relatives, raise flags. Look at these other things that also contribute to ovarian cancer. Infertility, that be something to do with the fallopian tubes. Endometriosis, that be something to do with the fallopian tubes. Look at the things that decrease risk factors of ovarian cancer. Birth control pills. Oral contraceptives that contain estrogen and progesterone hibernate the ovary. When they are used in young women, they are extremely safe, and they hibernate our ovarian cycle in a very good, safe way that reduces our risk of ovarian cancer. Say 50% reduction for 2 years. You use the pill for 8 years or more, it's an 80% reduction in your lifetime risk of ovarian cancer. Breastfeeding helps. Previous pregnancy, also protective. And tubal ligation, 50% reduction. Again, what's going on? If we interrupt those fallopian tubes connecting vagina and uterus with the skin on the pelvic peritoneum, we are interrupting an inflammatory process, metastatic process, brings ovarian cancer into the pelvis. So here it is. This is a recent concept, and they break down cancers into slow ones and fast ones, sort of like they were talking about with breast cancer. The hormone-sensitive ones are slower usually, and the triple negative are worse and faster. And so ones that aren't quite as bad have their precursors in ovarian cysts that don't go away or endometriosis. 1% of women with endometriosis will go on to have ovarian cancer. And the type 2 ones are the ones that suddenly go very quickly and come from the fallopian tube. So what's endometriosis? Because I'm bandying about that word, and a lot of you guys may not know what it is. Basically, it's when the lining of the uterus metastasizes like a cancer, the skin inside the pelvis. And the major theory is that it's stem cells from menstruation are being recycled through the fallopian tubes. About 10 to 15% of the blood you bleed every month does that. If you tie your tubes and are still menstruating, you might have heavier flow, 10 to 15% more, because you're not recycling that blood, okay? The other theory is that just there's a chronic irritation, maybe some crazy macrophages, and they make the skin on the peritoneum turn into a different cell type. In Japan, there have been some recent studies that also link this endometriosis bacteria. So, I'll talk briefly about dysbiosis, or having the wrong bacteria in the vagina. And when women have low estrogen levels, that can be a risk factor for growing the wrong kind of bacteria. There are also a lot of activities that can make it more common as well. Trichomonas, using a G-string underwear, spermicide, all of these are linked to having unhealthy bacteria in the vagina. Women with this unhealthy bacteria in their vagina have increased rates of endometrial, cervical, and ovarian cancers. Where do we get the bacteria from? Well, there's a connection between our gut and our vagina. This is why you eat the Activia yogurt to get your probiotics. Don't apply it correctly. We don't have that works yet. Also, I wanted to make a point about the gut and what's growing in your gut and why that's important for the big picture. I recently had chemotherapy, and there are lots of rules when you're on chemotherapy. I didn't have Keytruda, but a lot of breast cancer patients do have this checkpoint inhibitor, which can be an amazing chemotherapy that stops the cancer in its tracks. But it will not work if you take antibiotics during your therapy. There's something about having healthy bacteria in your gut that allows your own immune system to do its job properly. So when we're eating foods that are highly processed, with additives we don't know, what is this doing to our gut? Studies are showing that when we have a higher fiber diet, we have better bacteria, we have more natural GLP-1. Those of us who aren't ready to go on Ozempic yet, we need to take our fiber. About basically, we have our prenatal genes, and then there are other epigenetic effects, what genes get turned on and what genes get turned off. And some of that is going to be out of our control, something we were exposed to in utero. Some of those things are going to be in our control. I want you to remember that chronic inflammation leads to cancer. And I want to finally think about not delaying childbearing and supporting societal changes that would encourage healthiest reproduction. I think I would like to see more research include the AMH. For example, all this COVID stuff that happened with women having irregular periods, and there are 3 studies that even looked at AMH. One of them had 3 patients. So we're ignoring women's fertility if we're not looking at the AMH. And clearly, women's health is ripe for so many interventions. Thank you.
Thank you so much, Dr. Marshall. We'll open it up for questions from the audience.
Yes.
Hi. You mentioned the over-the-counter, the pill as a means of lowering endometriosis risk. I know that it's taken, to sort of mimic the natural cycle where you have 1 days on, 7 days off. What does the current research say, or the idea behind just using it continually versus trying to mimic the natural cycle?
It's wonderful. The whole John Rock, who invented the pill, was a staunch Catholic. He really wanted his church to accept this because natural family planning was acceptable. He said, "See, I'm making it natural. It's gonna, women are gonna get their period, and it should go through." And they excommunicated. So it turns out just turning it off is quite helpful. And the nice thing about the pill is that it does still give you back more, levels of those hormones to support your bones, brain, all of these things. And there are newer pills coming out. I mentioned the S-tetrol. It's a newer pill, Natasia, combines progesterone and Yaz, which unfortunately causes more blood clots than other pills because the spironone component of it is a bit of a diuretic, and together with the estrogen can make women get blood clots a little bit more easily. They thought Well, every other pill has this ethinyl estradiol. Let's try something bioidentical. It's not bioidentical, but it is, natural to babies' livers. So we're improving with pills, and absolutely, I think continuous pills are great. The only problem is that a lot of women get spotting on them at inopportune time.
Any additional questions? If there's any, for the folks online, if you have any questions online, please feel free to type in the chat, by the way, and we'll take any more questions here from the audience.
Okay, there's one question. Do you think an in-office preventative diagnostic hysteroscopy once per 2 years with a biopsy to detect cancers, microbiome, hormone imbalance, and visual uterine pathology, such as polyp, cystic fibroid, chronic inflammation?
Didn't catch all of that. It was asking, do we need to do hysteroscopy?
Once every 2 years with a biopsy to detect cancer, microbiome, hormone imbalance.
It's in the chat if you want to see
it. I do not. That's not the standard of care right now. It may be someday. Right now, there are definitely lots of companies asking people to send in their stool samples for microbiomes and that sort of thing. Zoe is one of the companies, and 30 plants a week challenges, but we don't usually do hysteroscopy and biopsies unless there's an abnormality like abnormal bleeding after the age of 35, or spotting at the wrong time, or if a postmenopausal woman on hormone replacement therapy has a lining of her uterus getting thicker on ultrasound. Those are reasons to definitely take a look and biopsy. But we don't test microbiome. I can't call LabCorp or Scripps or UCSD and ask them for microbiome assay in the uterus. Maybe Dr. Brewster, urogynecologist, has some studies about that. And urinary, the urine is sterile. It's not. It's actually, there's lots of stuff there. We just don't know how to look for them at the time yet.
So ovarian cancer, it's still very lethal and fatal, and is the diagnosis of that quite late? And can you sort of offer any potential solutions for preventative measures that are on the horizon, and diagnostic measures for ovarian cancer?
That's a great question. There are some blood tests that people are trying to develop. The original CA-125 that they looked at, and the BRCA patients like Gilda Radner were doing ultrasounds every 6 months and CA-125s every 4 months. And although they would pick up the cancer a little bit earlier, they were dying just as quickly. There's some larger panels that are available whenever a woman has an ovarian cyst that we're not sure what to do with, especially if they're over 35. I'm a surgeon, so I say, if it's not normal and it's giving you symptoms, take it out, because it may be just endometrioma now, but there's a 1% chance when you're in your 60s, it could be something more serious. And those slower lesions in forming. Really sad ones are the BRCA1 and 2, the fallopian tube ones that really go the fastest. And they're almost always diagnosed at stage 3 before we can do anything about, before we can catch it at an early stage.
Would you recommend, as a prevention, to remove our fallopian tubes after childbirth, or it's pretty,
Yes.
that's pretty drastic, to.
It is and it isn't. Ovarian cancer isn't that common, fortunately. I've made this speech to many of my patients. If I was the Surgeon General, I'd ask every woman in their 20s to be on the pill for 2 years, just 2 years. And that would be very significant in reducing ovarian cancer. But I do like to sterilize women, to tie their tubes or to remove them if they're, if that's available. The surgery to remove the fallopian tubes is usually 3 little incisions. The surgery to just burn them and cut them is 1 little incision that's invisible. So women still choose to leave fallopian tubes behind, but a little bit better for their risk. But yeah, it's difficult to sign people up for elective abdominal surgery, but if you are there for other things, it is recommended if you've completed childbearing to remove those.
Thank you so much, Dr. Marshall.
My
Give her
pleasure.
another round of applause. Thank you.